Managing a cardiac emergency. As I introduce myself, I'm Dr. Salman Salahuddin. So what has happened? What do you do when you see something like this? Okay, so this guy is just slumped. He could be having a lot of things. He could have had, like the doctor said, he could have had his sugars down, anything. But he could also be having something else. Could it be a cardiac arrest? Could it be a cardiac arrest? Could it be a heart attack? Yes, it is possible. In the particular given situation, it could be that. Okay. So now comes the next question on your screen. Cardiac arrest and heart attack. Are they the same, one and the same? True, false? So if you guys just vote on your screens right now. For those who could not join us, just go to menti.com, just go to a browser, go to menti.com and put in the code which you see on the top, 106426, for those who joined us late. Okay, so we've got a good voting right now. We are sort of like 50-50 who thinks that cardiac arrest and heart attack are the same, one and the same, and there's a slight majority who thinks there is some kind of difference. So is there a difference? So some basics first is what I'd like to touch upon. Heart attack, like how Sudeep just now said, you have your coronary arteries, there is plaque built up and it suddenly just blocks off. The artery was flowing till 5 minutes back, it suddenly just blocked off, and that part of the heart muscle which you see on the bottom suddenly just necroses. There is damage that causes pain. That's all. He does not have to fall flat. He will talk to you and tell you that I'm having pain. So that is not a cardiac arrest. Okay? Just to know, like how we said earlier, what scares you the most. If you look at this graph here, 25%, you can see the red, 25% of all deaths in this country happen because of cardiovascular disease. And as I mentioned, it is more than all combined, all cancers combined. And actually the second comes is respiratory disease, and number 3 at 5% only is cancer. So there lies the importance of recognizing a cardiac emergency and tackling it appropriately. Okay, so this, as I said, was a heart attack. You have necrosis, there is sudden blockage, the muscle doesn't have blood supply, you get pain, but he's maybe, most of the time he's conscious. He's able to tell you what his problem is. He's having pain, breathlessness or something. These are the signs. It can go to the left arm, neck, jaw, whatever. And there can be perspiration, sweating, nausea, shortness of breath, upper body discomfort, anything which is abnormal, which he had not experienced in the past before. Okay, so that was a heart attack. So then what is a cardiac arrest then? Okay, now that's what is interesting. Now, sudden cardiac arrest, and that was something like a plumbing problem. There's a flow problem. Plumbing issue. This is an electrical problem. Here what happens, due to certain reasons, there is some electrical instability of the heart. Heart suddenly fibrillates and it just stops. It stops pumping. And thereby, because of this electrical instability, there is sudden cardiac arrest. Now this, most often it is because of a heart attack. A heart attack in 20 to 30% of cases can lead to a cardiac arrest. Most of the time it does not. There are other causes of cardiac arrest also. So this causes basically abnormal cardiac electrical activity. There's rhythm disturbances, cardiac malfunction. There are many causes for a cardiac arrest, like for example, young athletes develop cardiac arrest. Those are because of electrical problems, biochemical problems. They can have cardiac arrest. Footballers, athletes, they are not having heart attacks. They get cardiac arrest due to several other reasons. And one of the reasons is a heart attack. So that is the difference between a cardiac arrest and a heart attack. So cardiac arrest is an electrical problem. The patient will be unconscious. Start CPR. In a heart attack, it is a circulation problem. The patient usually will be conscious. Call for help. Okay? So that's some basic. If you want to draw, like in engineering terms, there's a Venn diagram. There is an overlap, but they're not the same. Ladies and gentlemen, how many of you can you confidently perform CPR, cardiopulmonary resuscitation? Yes or no? So we've got a good majority who thinks that they cannot. But that is sad, no, because 70% of all cardiac arrests happen at home or at the workplace. 50% of all cardiac arrests are witnessed by somebody. That means half of you may probably witness something in the future life, and what will you do? 83% of our population who are sitting right now cannot confidently perform CPR. This is important. So this question does not receive much listening. Have you received formal training in CPR or BLS? Yes or no? Have you received formal training? Could you just type yes or no? So again, we have 95, there is a good 5% who have received, I think a big round of applause for them. Yes, and I think the mantra for today is that we should achieve 100% BLS trained. BLS is just a few hours job. Like they say in the West, you can be trained in by basic life support in the time you get to watch Lucifer or Dil To Pagle or whatever. In those 3 hours, you can be trained how to save a basic life support. That's all it takes. So the key concept is once you have cardiac arrest, there is blood standstill. Okay, there is no heartbeat, there is no oxygen to the brain stops. CPR can keep the brain alive by pushing the blood to the brain. That's what it does, oxygenates the vital organs. That's what CPR does. You push, you're pushing blood into the brain. So you should understand, loss of blood to the brain can cause brain damage in just 4 minutes. 4 minutes, you don't do anything, look for water, look for aquafina and all that. By the time his brain is getting switched off. And within 4 minutes, his brain is going to get conked off. By 10 minutes, you've lost him. Somebody tries to call KMCT, MIMS, somebody come, by the time he's gone. You need to know what to do at that point of time. So what is CPR? Basically it's a combination of rescue breaths and chest compressions. So breathing and compressions, and that's what. Rescue breathing provides oxygen to the person's lungs, and chest compressions tries to simulate your cardiac contractions. That's what CPR does. Fact, every minute without CPR, survival rate decreases by 10%. Every minute you're going to delay, his chances of survival keeps going down by 10%. So by around 10%, that's why I said by 10 minutes, he's gone. If he's having a cardiac arrest. So in CPR, as you can see the diagram, the first diagram shows, we can have our, so in our first diagram, you can see the heart which is fully expanded. You're pushing it down, the heart is squeezed. So you're squeezing, heart pumps. Leave it, again fills. This is what we do in cardiopulmonary resuscitation. So the important thing, I'll just have one of this is Mr. Munir, one of our senior EMS technicians at our hospital who is involved in a lot of basic life support. He's trained more than 5,000 to 10,000 people in basic life support, and he's a champ at his job. And how basically, I cannot give you a formal training, but just a quick few steps. So the basic things is, previously they used to call it ABC, now it's called CAB. C is for circulation or compression, airway and breathing. Okay, this is what we're going to do. So this is the sequence: compression, airway, breathing. Okay, so we'll start. First, establish response and tap. So first thing when you see a patient, like how you check the area, and then you're going to tap the person. Okay? Yes. Yeah, so just pause one second. So what he did was, he taps, looks for this thing, calls for help, looks for breathing, looks for the pulse. He's not saying, do you have an AED? Bring the AED. Bring AED, call help, look breathing, look for pulse, and starts compression. So this is what he's going to do in compression. So this is how to determine pulse, okay? And this is the compression. Just show how the first, you put your left hand, just show your left hand, Mandir. Put your left hand first, E technique, yeah. First, whichever we choose. One hand on top, yes. One hand on top. And the other hand, you lock it like this, yes. You lock it, and with the heel of your palm at the center of your chest, go for it, yes.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Yeah, so one cycle contains of 30 compressions and then 2 breaths. Note the point here is that, just put the positions in front of the elbow. So the elbow here is locked, okay? There are a lot of people, this is wrong. You're trying to push with your palm. That is wrong. The fulcrum is actually your hip. This is locked. The elbow is locked, and he is giving the weight from here. It's going like this. So the body weight is going on. You don't do this. You're not doing a massage service there. Your elbows are locked, and you're using the fulcrum is actually at your hip, like this. You're going like this. So there you give effective, so the another mantra is high quality compressions. You just do like this, nothing's going to happen. You give that and then give, if you're possible, there are two methods. You can do only hands only CPR, and if you're equipped, you can also give 2 breaths if you want. How do you give a breath? Okay, I'll just show the airway. Okay, the head should lift.
Head lift and chin lift. In the nose, also what? 2 breaths.
So you lift the chin, lift the head up. You can put a kerchief just for sanitary sake, and then give 2 full breaths. Look for the chest lift. Look that you have given enough breath so that the chest is, do not spend too much time on breathing, because then restart your compression.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13.
Note his position whereby his elbow is locked and he is moving his whole body weight onto the this thing. This is high quality compression. Mind you, this is going to be what is going to save the life of some near and dear. So you count till 30, so you do one cycle, 30 compressions, 2 breaths, check a pulse. If you know how to check a pulse, check a pulse. If you're getting a pulse, that's it. Good, you can stop compression. You check his breathing. If he's still not breathing, you keep continuing. If he's breathing also and you've got a pulse, you can stop your CPR and put him into a recovery position. So that's a recovery position whereby he's on his side, and so that his secretions can all come out. So, thank you very much. Thank you very much. So, so that was, if you had an AED in between, okay? If you had an AED in between, what would you do? If an AED came in between, you would just strap it on. Yeah, so he's got an AED, so fantastic. Yeah, so in between your compression, you suddenly just take your AED, strap it on, it shows where to put. It gives you voice prompts on what to do. Yes. So one is on above your right nipple and one is below your left nipple. So then you connect it and then it will start analyzing the rhythm. If it is analyzing heart rhythm, that's what it said. Do not touch the patient, stand clear. You have to pause CPR. Shock advised is what it said. That means the AED is recommending shock. Stay clear. Press the orange button, deliver shock. You press it and now the patient is going to get shocked. So you do not have to use your brains. It is using his brains. It's going to shock. Because if it is in ventricular fibrillation, like how I showed you, it's fibrillating, the only thing which it can convert is this guy, not your CPR. Else you have to take him to the hospital and then somebody will give a shock over there. So AED is paramount for a person to succeed. I still, frankly, for the life of me, I don't know why it is not available in most of our major institutes or in corporate establishments in our country. So to sum it up in CPR, start early CPR, thank you again, high quality CPR, push hard and fast, minimize interruptions, don't chit chat in between, and allow the chest to fully recoil so as some feeling is happening. Compressions are most important. If you don't want to give breath, there is also a thing called hands only CPR, whereby you just keep giving compressions. You don't need to give breaths is what they say nowadays also. If you have some inhibition of doing a mouth to mouth, at least hands only CPR has got a nearly equal chance of survival and maybe as effective. There's a huge movement going on in the West where it's called hands only CPR. At least you do this, his survival chances are very, very good. Even if you don't give the breaths, because some oxygenation may happen from the air itself. So the 3 steps to restart your heart: call for help, push, shock. Call for help. So this is what we need to do, not bring Aquafina water. Could I really do it? That's the question. Would I be able to do it in need? So the first step is not knowing. We don't know. 85% don't know about CPR. Now you know a little bit. You have understood a little bit. Then get trained. And then at the time, having the presence of mind and doing it properly in a high quality way is the way we can do this thing. As I said, like for example, in the US, there are more than 3 lakh people are struck by sudden cardiac arrest. And less than 10% survive. I'll give you another shocking statistics here. Okay, around 3.5 lakh people die of sudden cardiac arrest, like a person who's suddenly collapsing. Look at this, bystander CPR is 46%. That is around 50% of these 3.5 lakhs were attended to by a person like you and me, and who did CPR at the beach, at the office, at home. 50% actually got CPR. Still only 12% survived. So that's the statistics here. Here in our country, not even a single figure percentage would be there for bystander CPR. So you can imagine our survival rates. So that's what we need to focus from a country perspective. Sudden cardiac arrest can strike anytime, anywhere, anyone, even if they appear healthy. As I said earlier, 70% of all cardiac arrests happen at home, 50% of all are witnessed. Get trained. Getting BLS trained is a very simple thing. You just need to know that there is such a concept like that. Save a life, you'll be glad you did. Thank you very much. If anybody has questions, you can also put text questions on your phone. It'll come up on screen and we'll be happy to answer before our next talk. Anybody want to put a sample question on the screen? Like you can say, I am getting bored. It'll come on the screen. Yeah, so we have the standard joules are, you have, so ranges from 100 to 200. So basically for effective, this thing, 150 joules minimum. Yeah, so you have you have your biphasic, your sine wave is basically, yeah, sine wave current is what is being given. Don't ask me too much about electricity, but still this much. Yeah, so it's 150 to 200 joules is what we give. Okay, so we got some comments here. It was great, thank you. Oh, thank you very much too. If there's any questions, which are great information. What is the effect of keto diet? The Keto Master is here. Many of you would have seen his YouTube video, which has become famous or infamous.
I'm still alive, thank you. Yeah, I think we'll move keto or in the last. We'll take it in the last, yeah. And I'm Shafiq. Good evening, everybody. First of all, I would like to thank NIT authorities to give us a platform like this to interact with you guys. And then I thought I would talk about how you great guys help us delivering care in patients with heart disease. So we'll see how technology has helped us to improve cardiac health. So we all are interventional cardiologists, so we do catheterization without open heart surgery. So we put tubes here and there and treat the heart disease. So the things started way back in 1929 when a resident in Berlin, he was a surgery resident, he had a crazy idea of why not put a tube in the vein. Anyway, the vein goes to the heart, so it will go to the heart, and we can take pressures, we can take give fluids or medicine directly into the heart. And he did this proposal to his boss. So that was in 29, Hitler's Germany. The boss said, no way, it's a crazy idea. No, you cannot do that. Then when the boss was on a conference leave, so he decided to do it by himself. So he took a nurse's help, went to the procedure room. The nurse put a incision in this antecubital vein, which is the vein that we use to take blood from, and put a long tube which is used for to drain urine into the heart. And then actually he knew that he was doing something historical, so he didn't want to share the glory. He tied down the nurse in the chair and he walked by himself down to the X-ray department and took an X-ray. That was the first ever cardiac catheterization in history. The professor was back, he didn't like, he was fired, and he didn't even get cardiology. He became a urologist later on. But 27 years later, he was awarded Nobel Prize. His name was Werner Forssmann. Even though he lived, he actually did some inventions in urology as well. So after that, there was a greater understanding of what is happening inside the heart, the pressures, the mechanism of disease and everything. So it aided initially about delivering medicine, delivering better medical care. Then it became, people thought, oh, we are putting tubes, so let's do put some treatment devices as well. So earlier, then the coronary artery disease was diagnosed, and the bypass was started as early as 1968. And another 10 years later, for the first time in the history, coronary angioplasty, which is like dilating a blocked artery with a balloon was done by Andres Grunzig. He was a Swiss cardiologist in Zurich. So this was a historical step. After that, there was increased research, and there was enormous growth of treatment, patients number who get treated by these methods. Now it has become so common, the disease is common, the treatment is also common. So this Dr. Sudeep had shown this anatomy on the cardiac heart surface. There are arteries which are seen in the red, and when they develop block, when they develop all these symptoms which was discussed here, then it is sometimes we may have to treat it urgent basis, sometimes on an elective basis. But mind you, this is just a repair. നമ്മൾ കാർ വാങ്ങി കാർ കേടായി കാർ റിപ്പയർ ചെയ്തു, അതേ ഉള്ളൂ. കാർ കേടാവാതെ നോക്കുക എന്നുള്ളത്, that is what is more important. So prevention always is the most crucial, and even in scientific studies it is proven that survival or longevity is increased only by diet as well as exercise, not by angioplasty or bypass. In larger perspective, they do repair and bring back to life. Now, I'm not here to discuss mundane stuff. I thought I'll see a technological. This is an optical coherence tomographic video. Here, you can see a catheter or a catheter is passed into the coronary artery, deep inside the coronary artery, which records this reflected wave from this infrared light and puts it into a picture. Now, if you can see, this is a wall of a coronary artery disease, and if you can see square blocks here, they are tiny struts of a stent which is put. So we are actually assessing whether the stent strut has actually adhered to the vessel wall or not. So this is one revolutionary imaging modality where we can improve the quality of the therapy that we just delivered. Another one, rotablation. Rotablation is when traditionally we do coronary angioplasty, we put thin balloons, dilate it, and then put a metallic stent over it and come back. But in tough lesions, if the balloon doesn't go, if the balloon can't open the things, so we use hard stuff. This is a burr over a wire which is connected to a rotational device which can rotate very fast, and the tip of this burr is with diamonds. So it can actually cut through severe calcific stenosis and go through it and make way of delivering balloon and stents. So that's another one we use in coronary artery disease. And apart from that, there are many defects that people have inside the heart. They can be born with holes in the heart by birth. Holes may be acquired when they develop heart attack and some injury. So in such cases, we can actually now close holes without opening the chest. So the surgical treatment, which was the practice earlier, has been replaced in large majority of patients of such disease with interventional treatment without anesthesia and opening the chest. So we can actually, if the valve is small, we can open it with a balloon. And if there is a leak coming from one chamber to another chamber, we can put coils and block it. So these are some methods where technology helped us to treat patients. So here you can see ASD, which is one of the most common congenital problem, atrial septal defect. These are the 4 chambers. These are the 2 atria. A defect in the wall separating these two is called an atrial septal defect. So people are born with it. So earlier we used to do open heart surgery and close it with a membrane. Now we can close in 90% of cases with a device which is taken through a blood vessel in the groin. So you can see this is the principle. This is a device which is coming out of a tube. This tube is coming all the way from the groin, and it's like a plug. So there is a disc here and there is a disc here meant to be on the other side, and with a waist connecting these two, and it kind of self-retaining and remains there. So this is the device. This is made of nitinol. It's an alloy of nickel chromium, and it has a fabric inside which when it touches blood, it clots, and it in fact prevents blood flow from one chamber to other. And there are two discs, and it is delivered like this. It can be collapsed into a tube, and when we push it from the groin, it opens like that. So we position at the chamber, and we do that. This is actually exactly in a patient's chamber. You can see when disc has come. This we are doing in fluoroscopy, X-ray cine, and you can see the two discs which came. One is on the other side, and this one on other side of the defect, and which will, with a waste connecting it, and then it becomes closed. And now you can see that it is taken through a cable, and we unscrew it and deliver it. Everything can be done with a local anesthesia. Patient is conscious, patient can talk to us, and in 2 days the patient is at home. Similarly, these kind of diseases, ventricular septal defect between these two ventricles. This is another disease where there is an abnormal connection between these two. It's called a PDA, patent ductus. All these are closed by same principles. This is another disease, coarctation, what we call as by birth. People, kids are born with tiny aorta. This is the normal heart with an aorta or a major blood vessel coming and going like down, and they can have a constricted portion here, so the children come with high blood pressure and all. So we can actually do balloon dilatation. You can see here, this is the portion which is this actual picture. This is a constricted portion, and it can be treated by balloon dilatation and metallic stenting. Now this is one area where valvular heart disease is it was very common in our country because of the presence of rheumatic heart disease. You must have heard rheumatic fever, which affects the valve and damages the valve. So these valves become constricted or stenotic. They don't have the same surface area. They are supposed to open in each diastole where the blood filling happens, and it does not allow blood filling when it is diseased. So what to do? Earlier it was surgical correction. Now this is a balloon designed specifically for this, which is advanced from the right side. We put a hole in the heart, tiny hole, to advance this into the left side, and this balloon, a double barrel balloon, is positioned in between the valve. You can see here, and when we inflate the balloon, it is designed in such a way that the distal balloon is inflated first, proximal balloon then, and then finally the waist. Then it will just crack the valve, which is very tight. So this is again percutaneously done. In 2 days, patient can go home. This is the most exciting invention as of now in cardiology. Here the entire valve is replaced through a tube. So we call it transcatheter aortic valve implantation, or TAVI, which is most commonly used for aortic valve. This is the aortic valve, this is the left ventricle, this is the normal aortic valve. So in elderly people, the valve becomes stiff, calcium gets deposited, it doesn't open very well. So they can develop sudden cardiac arrest, they can develop angina, they can have heart failure. So when they are symptomatic, they need to get valve replaced by a surgery. Now, after 70 years, most of them are sick, they cannot go for an open heart surgery. So there came the idea. So this is how it is being done. Principle is similar to any intervention. In the artery, we make a hole, slightly bigger hole as compared to heart block intervention. The valve actually is being taken into this tube, collapsed, and it is advanced across the deceased valve. So when we unsheath this device, the valve just opens up, and there is a tissue valve inside this metallic frame, and from the next heartbeat, the new valve starts functioning. This is an animation video of it, and this is actually an actual picture. You can see that the collapsed valve I am positioning here in the valve position, and this is after how it looks like. The valve is now, it's a new valve in place, and they function. In this also, in 48 hours, 72 hours, they go home without a central scar. This is one of the latest, because there is one disease called mitral regurgitation. There is a leak from one chamber to other. So what happens is, you have to actually repair or replace the valve. So this is the animation of that. You can see that from this chamber, this valve is not fully tight, so it leaks, it causes heart failure. So surgeon used to put extra stitch and reduce the valve area so that the leak is less. Now this is a method, this is a clip, it's called a mitral clip to treat this without open heart surgery. Here with a similar principle, it is taken across the valve and it is actually positioned of the valve, above the valve, and after looking at the angle, and you can always tilt and adjust. All these are monitored using an echocardiogram through the esophagus, and then you can actually, it just holds the leaflet here. It just holds the leaflet here, and it just like a stapler, it just clips. And it is converted to 2 small holes where the leak is less. Now you can reposition. You can, if there is a leak again, you can put one additional clip, and the regurgitation stops immediately. This is also done from groin without open heart method. So in short, there are several ways the technology and human care go hand in hand. And I thank you all for your patient listening and for giving me this opportunity. Thank you. Yeah, I would like to answer some questions if there are some.
Doctor, statins can damage your cardiac tissues. Many studies have not done because you don't get autopsy of patients who have been on statins. How do you comment on that?
We have actually autopsy study because many Scandinavian countries, European countries, most of the states of America, if a patient dies of without unknown cause, there is something called medical autopsy, not a legal autopsy. So, sorry, in India it is not done. We are way backward in research and this thing. In India it is not done. We are living in a country where organ donation is at risk. Can you all believe? Organ donation, that is a cadaveric, which is one area where you actually give life. I think from NIT there are, I think you all must have heard stories about how families, are relieved by getting organ when they have their son or daughter are sick and in the deathbed. But now, because of certain heightened awareness, I should say, too much heightened awareness in society, there has been a lot of negative talks going about organ donation, which has actually reduced the number of, it is actually sad to come from an educated state like Kerala. Now, coming to your point, we don't have a research program because we don't have autopsy. The moment we say post-mortem in a dead patient, everybody becomes violent. So we have not reached that level of acceptance. And but there are autopsy studies, a lot of autopsy studies. There are regression trials. Regression trials are trials only aimed at whether or not this block regressed due to statin. There are many regression trials. Actually, statins all came after regression trials. So there is no doubt about what is the efficacy of statin. Now coming to, should everybody take statin? No, no way. The first treatment of any hyperlipidemia is lifestyle change. You change what you eat, you reduce what you eat. The amount is so important. You have to go for a diet, caloric requirement of your height, weight, and your age.
Yeah, okay, we'll just go to a quick quiz. These are 5 questions for you guys to get interested. You'll be prompted on your this thing to write your name and join the quiz. Enter your name and press join. And if everybody is okay, Okay, so we've got 45 people who have joined. A lot of people are, okay, yes. And then if everybody is joined, we'll start our director sir is not participating in our esteemed quiz. Okay, so we'll start our first question. So whoever answers first and correct gets the correct answer. Your heart stops beating when a heart attack strikes. True or false? Your heart stops beating when a heart attack strikes. Is it true or false? You do answer on the mobile phone and your answers will come right now. And a lot of people have answered, and the correct answer is false. As I said, heart attack, your heart does not stop. That is the correct answer. And the person who won in that round is Chakradar. Okay, no problem. We still can go to the next question. Answer fast to get more points. Fast and accurate. If you experience some new chest discomfort, what should you do? Take gas medication and see. Consult a doctor. Climb 2 flights of stairs to see if it is okay. Or do deep breathing exercises by Ramdev Baba. If you experience some new chest discomfort, which of the things should you do? Okay, there are some people who wants to do some breathing exercises. The correct answer is consult a doctor or take some preliminary investigation. That is the right answer. And after the second question, the leader is again Chakradar and Shafiq. Okay, not to worry. And the next question, we have 3 more questions before we wrap it up. Who is the President of India? Ramnath Verma, Ramnath Sharma, Ramnath Kovind or Ram Gopal Verma? Many people will get it wrong. So Ram Gopal Verma is like a, yay, great. So there are people who still got it wrong. Okay, fine. So that was the correct answer. Ramnath Kovind is the correct answer. And okay, fastest is Nala. Okay, no problem. Next question. What is a myocardial infarction? Look at your phone. What is a myocardial infarction? I didn't mention that. Is it heart failure? Is it cardiac arrest? Is it a heart attack or all of the above? I didn't mention it, so again, this is just general knowledge. In medical terminologies, when we mention what is a myocardial infarction, are we referring to a heart failure, cardiac arrest, heart attack, or does it mention all of the above? So a lot of people thought it's all of the above, but the correct answer actually refers to a heart attack. The medical terminology for heart attack is called myocardial infarction. And the scoring after that question comes to Shafiq is the fastest over here. And I think the last question probably. TAVI or tower, which Dr. Shafiq mentioned, is used for which condition? Tower is used for aortic stenosis, aortic leakage, mitral stenosis, mitral leakage. It is a tough question, but he did mention it. It is used as a non-surgical option to treat some valve condition. Which is it? Aortic stenosis, aortic leakage, or mitral stenosis or mitral leakage? The answer is actually aortic stenosis, which is the narrowing of the aortic valve. That is the correct answer. And let's see. Okay, a lot of friends, Anwar and Linish only got this answer. And I think this is the last question here. Most useful test in diabetes is fasting blood sugar, postprandial blood sugar, random blood sugar, HbA1c. Fasting sugar, PPBS, that is after food, a random blood sugar, or HbA1c, which is glycosylated hemoglobin. I don't know if anybody's heard of that. Which do you think is the most? So fasting blood sugar, yes. The answer is actually HbA1c. Sudeep just said 2 words on that.
HbA1c is actually an average of blood sugar over the previous 4 months. So that shows a diabetic control, because once you go to the doctor, you feel like controlling your sugar, and you can have a fasting blood sugar which is normal. My grandmother used to do all the time. Now once HbA1c's come out, it's not possible to do that. People, doctors will know you control.
Which of the following can be treated nowadays without surgery? Artery blockages, aortic stenosis, hole in the heart, all of the above. Artery blockages, aortic stenosis, hole in the heart, all of the above. It's a very easy question for you to get some extra bonus points. Which can be treated today without surgery? Yes. So there are still people who think that some may not be treatable, but the answer is actually all of the above. And we'll go to I think this is the last one. Sudden cardiac arrest means that the heart is beating dangerously slow, artery is clogged, stopped completely, or alternating slow and fast beats. What does sudden cardiac arrest mean? Beating very slowly, arteries clogged, stopped completely, or alternating slow and fast beats. Stopped completely is the answer, but there are still people who actually think that artery is clogged. We told you that the heart completely stands still. That is what refers to as sudden cardiac arrest. And that's good. So the next question is, how many NITs are there in India? See? Good. 29, 30, 31, 32. How many NITs are there in India? Local question. Home base. This, let's see how we get correct. Okay, so the correct answer is 31, which a good 50% did not get. So the 31 NITs in the whole of India. Sir. Thank you very much, it's been a pleasure. Okay, I'll just announce the winner for this thing. The winner is getting calculated. It's a complex, computerized, algorithmic calculation, highly accurate. And the answer is Anju with 5245 points. I think we'll invite Anju onto stage. Director sir can give one small gift to our first prize winner. Okay, we'll invite, it's a small token. It's a coupon which entitles Miss Anju to a complete cardiology checkup to see if she's got any problems. Yes, and we have, sir, one more. Let's see who's the next. Nala, N-A-L-A. Yes. And third place is Pangan. Sir. Sir. Oh, yes, sir. Thank you very much, ladies and gentlemen. It's been a real pleasure interacting with you all. So on behalf of all the faculty from Aster MIMS Cardiology, we extend a very warm gratitude to all the faculty, Director Sir, Registrar and Dean Sir of this institute, and all of you who gathered here to listen to our interaction. Hope some of it struck home and had some take-home messages for you to take home back today. Thank you very much.
Thank you so much for spending your valuable time interacting with us. As a token of our appreciation, we would like to present mementos to our guest. I request our Honorable Director, Dr. Shivaji Chakravarti, to hand over the memento. I request Dr. Shafiq Machumal to come forward and accept the memento. Thank you, sir. I request Dr. Salman Salahuddin to come forward and accept the memento. Thank you. I request Dr. Sudeep Koshikurian to come forward and accept the memento.
She is the only person who can scare his wife.
Thank you, sir. Next, I invite Dr. Fias to come forward and accept the memento. Now I invite Mr. Munir to come forward and accept the memento. Thank you, sir. Thank you, Director. Now I invite Dr. S.D. Madhukumar, Dean Students Welfare, to propose vote of thanks.
So, respected dignitaries in the present here, it was a wonderful workshop. I think all of us got benefited by this BLS workshop. So, on behalf of the institute, I thank the entire cardiology team, cardiology department of Aster MIMS for coming over here and conducting this workshop for the benefit of the faculty and staff and students of this institute. So let me say their names once again. So we had the CEO of Aster MIMS, Dr. Sandy Sargent, who are present here, and Dr. Shafiq Martingal, Head of the Department Cardiology, Dr. Salman Salahuddin, and Dr. Sudeep Koshikurian. So on behalf of all of us, I once again thank for them for coming over here and spending their valuable time. So they are very busy cardiologists. Actually, the HOD, Dr. Shafiq, was attending a case, I think at least almost 45 minutes back. So he's coming from the operation theatre. So we respect our heartfelt thanks to the entire MIMS team for coming over here and conducting this workshop. We will have many such BLS training programs soon. I think the team from Health Center is planning many such BLS certifications or BLS programs in near future. And I formally thank our director, Professor Shivaji Chakravarti, and our registrar for giving full support for conducting this program. So I thank all the audience, all my faculty colleagues, other students, research scholars, all who have come here and attended this program. And last but not least, our sincere thanks to the volunteers who were helping us in organizing this program. Thank you.